Growing up, I visited India every 4 to 5 years, and given that both sets of my grandparents lived in the same city, you could say that I was a hot commodity between the two homes. However, either because I lived across the world from them for the majority of my life, or the fact that I was less than 12 years old, I often overlooked huge red flags in their health. At 8 years old, I assumed that my grandfather's sudden immobility in his legs was just due to his age. What I didn't realize was that the real reason for his progressive drop in his legs' functionality was due to diabetes. And it wasn't just him. For years, I somehow glossed over the seriousness of diabetes in conversations between my dad and my uncle, discussing their varicose veins and the need for corrective products like compression socks to mitigate their neuropathy. Now, it being several years later, I know with a renewed appreciation what these measures meant. Before we get into it, I had the pleasure of speaking with Dr. Robert Frykberg, who was kind enough to answer my questions about diabetic foot while I was doing my research to make this video. Here is his brief introduction.
Robert Frykberg. I'm now at the University of Texas in San Antonio. And my specialty has been diabetic foot for many years. Before it became popular as it is now, while diabetic foot issues were extremely common, as they always have been for the last 100 years, there weren't a lot of specialists in it. So I've been specializing in this for quite a long time now. I do more clinical, but I've also published quite a bit over the years, engaged in research on wound healing products, on reviews of diabetic foot. So it's been a combination of clinical, a lot of teaching, and a lot of writing, and a good portion of that time was also involved in research, mainly focused on diabetic foot infections, diabetic foot complications.
To put diabetic foot complications into context, about 50% of adults with diabetes globally experience diabetic peripheral neuropathy, one of the most common complications in feet, with the specific statistics per country ranging between 6% and 51%. Similarly, it's predicted that diabetics have a 19% to 34% risk of developing the next most common complication, foot ulcers, which other studies find currently affect more than 18.6 million people worldwide and more than 1.6 million people in the United States alone. So with that in mind, I think it's important that we first understand how we can link diabetes with our feet, or anything else for that matter. The answer lies in hyperglycemia and two conditions that are found at the start of the chain of reactions of nearly every single diabetic complication. The first condition was what I took so long to comprehend as serious: neuropathy. But what exactly is neuropathy? The American Diabetes Association defines it as a diabetic complication that causes nerve damage throughout the body. We've already established that diabetics often struggle to regulate their blood sugar levels, either due to insulin dysfunction or a lack of insulin entirely. But this means that diabetics can be hyperglycemic, where their blood glucose levels are sustainedly high for prolonged periods of time with little in their control. Unfortunately, with high levels of glucose in the blood, nerve decay and nerve damage can occur at a heightened rate due to the body increasing production of enzymes related to the production of glucose byproducts like fructose and sorbitol. When the concentration of these chemicals increases as a result, cells experience osmotic stress or dysfunction due to the rapid water movement to accommodate these additional solutes or non-water molecules. At the end of the day, this pathway causes diabetics to have slowed or completely blocked nerve conduction, causing the nerve damage associated with neuropathy. In other words,
prolonged high glucose levels will lead to a disturbance of the membrane around the nerves, which reduces their ability to transmit a nerve signal, and reduced incidence of nerve sprouting, reduced incidence of tiny little nerve fibers in the skin.
The bottom line is that neuropathy causes someone to lose protective sensation by losing functionality in their peripheral nerves that are critical for pain communication, thereby making diabetics with neuropathy most susceptible to prolonged and untreated wounds in unseen places. The second primary cause and complication that predicates the majority of diabetic complications is peripheral arterial disease, or PAD. On its own, it's the complete or partial blockage of the peripheral vessels in the upper or lower limbs and is known to be associated with atherosclerosis in more major arteries. While the link has been historically underreported, PAD or PAD has been found to be significantly more prevalent in those with diabetes compared to those without. Similarly to how hyperglycemia causes oxidative stress by pushing glucose breakdown pathways to overproduce fructose and sorbitol, the same oxidative stress can be experienced by the cells lining the arteries, or endothelial cells. Additionally, hyperglycemia can cause the body to activate inflammatory pathways, because obesity, which is often associated with hyperglycemia and diabetes, causes fat cells to enlarge and become dysfunctional, provoking inflammatory molecules to be activated. Both, especially when combined, can cause arteries to become rigid, likely develop fatty streaks, and thereby prone to plaque buildup, predisposing atherosclerosis. This often then leads to PAD or PAD, causing especially the lower limbs to have poor circulation and healing capacities. So with all of this in mind, I know it's quite the mouthful, we can finally start understanding what exactly a diabetic foot condition is. Well, in simple terms, the Cleveland Clinic explains that these are skin, nerve, or circulation-related problems on one's foot due to diabetes, or has a heightened risk for complications due to diabetes. From here, there are levels of severity associated with the complications. One of the most common and lowest severity complications is a breakaway from neuropathy, called neuronal autonomic dysfunction, resulting in impaired sweat production. It sounds worse than it is, although it is pretty bad to begin with. Basically, what this means is that the glands responsible for lubricating the tissue on the foot become inhibited, leaving the foot prone to dryness, cracking, and fissuring. The next level of complication occurs from diabetic foot ulcers, or DFU. These are full-thickness wounds that are often located in the weight-bearing or exposed areas of the foot below the ankle. A wound might start as exactly that, a wound, but then get infected due to ignorance or persistent reinfection. As a result, it can ulcerate, the severity of which can be classified into 4 grades according to the Wagner classification. Taking it a little further, often diabetics have an excess of pro-inflammatory cytokines, a deficiency of stem cells, and a weaker immune response. All, when combined, cause the wound to enter a persistent cycle of inflammation. This is why a separate study finds that these can be also classified as non-healing wounds, which last on average to 12 to 13 months and tend to recur in patients about 60 to 70% of the time. The final level of this is gangrene in Charcot's foot. Gangrene is fatal and can be defined as a foot infection that goes untreated for long enough to cause blood to stop flowing to a specific part of the body. Charcot's foot, on the other hand, is a rare and late-stage variation of neuropathy that can cause permanent joint damage in the foot due to these microvascular complications. To understand these late-stage complications better, I asked Dr. Frykberg to explain if conditions really did build off of each other, especially within the context of foot ulcers. And to that, he said,
They do. Now, what would happen to you if you stubbed your little toe? You'd be limping and you'd take your shoe off and you'd baby it for a little while until it felt better. Well, imagine you had no feeling in your foot because of diabetic neuropathy. You just keep going on all day long. Can you imagine walking around with a hole in the bottom of your foot inside of a shoe and working all day and walking without any sense of pain? And then you do that for several days in a row because perhaps you don't remove your socks or see that your foot's bleeding or what have you. Then it becomes infected and you don't know that it's infected. Your foot might swell. You might notice that your shoe is becoming a little more snug, harder to get into. And then subsequently, you start thinking you have the flu. You start feeling feverish. You just feel lousy. You feel like you have the flu coming on. And I call that the diabetic foot flu because the flu-like symptoms are really coming from that raging foot infection that the patient can't even feel. And
Right.
they have eye complications like retinopathy or cataracts or blindness. They can't even see what's going on. And
Right.
that's only if they bother to check their feet every day. And most people don't check their feet every day. Most people won't even take their socks off every day for an inspection or change their shoes. So you can see how these composite effects can cumulatively combine to create not just a foot ulcer, that ulcer becomes infected because it allows bacteria to come in. And if you have uncontrolled diabetes, your immune response is not good. And then if you have bad circulation or peripheral arterial disease, it's called, you don't have the blood supply necessary to fight that infection locally because you can't get your immune cells there. So you can see how this just becomes a very vicious cycle that gets worse and worse and worse over time.
At the end of the day, diabetes can become really invasive, and so the main question on my mind is how can we prevent these invasions into our feet and anywhere else, really? Well, the answer is not really straightforward. Randomized clinical trials have found that slowed and controlled glucose levels in the blood can slow the progression of microvascular diseases like peripheral neuropathy, but never entirely halt or reverse it. The only problem is that the people in these clinical trials were also under very strict glycemic control via intensive insulin therapy, something that the majority of people like you and I don't exactly have access to. Fortunately, other studies have also found that weight loss and physical activity can be beneficial in managing neuropathy and serving as a preventative measure. Once again, while it hasn't shown to entirely reverse the effects of neuropathy, there is evidence to support that weight loss can stabilize neuropathy. Most importantly, weight loss and physical activity can help prevent and work against many of the circumstances that these conditions thrive on. For example, many conditions are linked to poor healing due to low circulation, inflammation, and in general, heightened glucose levels in the blood. Weight loss and continuous exercise both improve the circulation in the feet and more effectively manage these glucose levels, thereby short circuiting the very causes of these conditions. With all of this in mind, and to ease some minds, I wanted to share Dr. Frykberg's responses to some of my most pressing questions about what he has seen in the clinic dealing firsthand with diabetic foot conditions.
Well, it really depends. Where we are, there's so many non-English speaking people, poorer people who are not educated and are less likely to come in early, so therefore they come in late. They don't realize the problem. Unless you have a extensive family history of diabetes and diabetic complications. Those people tend to be more likely to seek care because they can remember their grandmother had an amputation or they started with an infection in the foot and then she had an amputation of her toe and then her leg, et cetera, et cetera. And then she died of a heart attack. So those people are more attuned to these complications and they'll come in sooner. But remember, when people have neuropathy, which is the overwhelming complication for lower extremity problems anyway, they ignore these problems many times until it's very late in the course of the disease or the course of the infection. They come in with gangrene or bone infection
Mm-hmm.
at the very first symptom, even the first symptom of diabetes. They never knew they had diabetes because diabetes can be a silent disease.
Right.
And so they have gangrene or a whopping foot infection, and that's their first time that their diabetes was diagnosed. That's it. It's the duration of diabetes. You can have chronic limb-threatening problems in your 20s if you've had diabetes type 1 since you were an infant or a child.
Mhm.
You could have, at 40 years old, you can be a double amputee due to the complications of diabetes, especially if you add on renal disease to it, requiring dialysis or renal failure. And that just compounds everything and magnifies all the problems. So it's really, when are most diabetic foot problems? Come on, if you look at papers published throughout the world over the years, maybe in 50s and 60s, people have the most severe complications, but that's just, let's say, a mean, but they're
Mhm.
younger or older. The funny thing is, people over 70, if you compare them to people under 70, they usually have a less likelihood of getting severe lower extremity complications. Probably because if they were going to get it, they would have already had it, or they're marked by taking better care of themselves, or they've had the disease long enough to know they have to take care of it. But it's very well, diabetes is so common now that most doctors, primary care, and other specialists are very sensitive to that. Symptoms are very classic. The problem becomes that not every problem in a diabetic foot, let's say, is due to diabetes. Not every
Okay.
problem in a diabetic patient is due to the diabetes. Like cancer and diabetes aren't necessarily related. And one can assume, oh, that's a diabetes problem, so let's get it under control. Or that wound on your foot is just a foot ulcer. Let's just control your diabetes and treat it as we would normally treat an ulcer without recognizing that maybe it's a skin cancer and that maybe that should be biopsied. So it's usually the diagnosis of diabetes is really fairly easy to make and because it's so common, but it's when you have other associated or non-associated problems coming along with the diabetes that it becomes a problem. And then there's a delay in diagnosis. And delays in diagnosis often lead to more adverse complications and adverse consequences.
To add to this, a lot of studies have been done about the crossover of skin cancers on the foot and diabetic foot ulcers. One study in particular found that because skin cancer and diabetic foot ulcers can appear similarly, most melanomas on the feet don't get accurately diagnosed. Unfortunately, about 35% of the fatal melanoma cases occur on the feet, highlighting why early diagnosis is crucial, as is biopsy as a second confirmation.
Largest myth is that you have a foot ulcer, you're going to automatically have an amputation. That's a myth. And it's not always the case, but it often is the case because people don't want to come in. They're afraid to come in because they're afraid that they're going to get amputated. And then they delay, delay, delay. And then by the time they finally are brought in, either on their own volition or in an emergency room, amputation becomes necessary. So the problem is people are fearing an amputation even at the early onset when amputation can most likely be prevented. And yet they're very much contributing towards the amputation because of their fears and their delays in coming in. So there's really a lot of consequences in delayed treatment and diagnosis. And that's a big
All
problem.
right. To wrap up, I think it's imperative to understand these what ifs because, as mentioned, they affect an overwhelming majority of diabetics in some way or the other. I will note, however, that a lot of these what ifs that are discussed here are not guaranteed to happen to you just if you have diabetes. It's just a possible track that I hope you will know now to try and prevent after watching this video. Of course, if you do your due diligence with foot exams, exercise, and routine checkups, you will likely be a-okay. As always, all the references that I used, additional reading material, as well as the transcript of this video will be listed on the corresponding blog on my website, which I will be linking below. I hope you learned something new today. I surely did, and once again, I'd like to thank Dr. Frykberg for humoring all of my questions and sharing his wealth of knowledge. Thank you for learning alongside with me. I'll see you all next time.